So, mutations in pheochromocytoma is the next topic. My name is Dr. Santosh Abraham. I'm one of the specialist registrars in endocrinology and diabetes in Scarborough General Hospital. So, mutations in pheochromocytoma basically do have two clusters of genes involved. So, cluster 1 mainly involves the hypoxia inducible factor, also known as the HIF. So it's a highly conserved transcriptional complex, and it's a heterodimer consisting of an alpha and a beta subunit, and it expresses aryl hydrocarbon receptor nuclear translocator. HIF1 belongs to the per-ARNT sim subfamily of the basic helix loop helix family of transcription factors. The proline residues by HIF prolyl hydroxylases allow recognition and ubiquinization of the VHL-E3 ubiquinone ligase. So this helps them for the rapid degradation by the proteasome. So this occurs in normoxic conditions. In hypoxic conditions, HIF prolyl hydroxylase is inhibited. Inhibition of electron transfer in the succinate dehydrogenase complex due to mutations in SDHB or SDHD genes can cause a buildup of succinate that inhibits HIF prolyl hydroxylase, and this stabilizes HIF1 alpha, and this is called pseudohypoxia. So HIF1, when stabilized under hypoxic conditions, upregulates several genes to promote survival in low oxygen conditions. So these includes the enzymes involved in glycolysis and also the vascular endothelial growth factor, which promotes angiogenesis. So HIF1 binds to hypoxia responsive elements in promoters. So it has been shown that muscle A kinase anchoring protein MAKAP organized E3 ubiquitone ligases also affects stability and positioning of HIF1. So depletion of the MAKAP or disruption of its targeting to the perinuclear region altered the stability of HIF1 and transcriptional activation of genes associated with hypoxia. HIF1 induction in normoxia is likely to have serious consequences in disease settings with a chronic inflammatory component. Chronic inflammation is a self-perpetuating, and it distorts the microenvironment as a result of these active transcription factors. So alterations in growth factor, chemokines, cytokines, and ROS balance, the reactive oxygen species balance, occur within the cellular milieu, and it provides the access of growth and survival needed for de novo development of cancer and metastasis. It's mainly the crosstalk between the two key transcription factors, NF, kappa, beta, and HIF, that happens. So HIF once again is activities involved in angiogenesis that is required for cancer tumor growth. So HIF inhibitors has been targeted as therapeutic Now coming to the second cluster, which mainly involves the PI3K, AKT, mTOR pathway. So this is an intracellular signaling pathway important in regulating the cell cycle. So it is directly related to the cellular quiescence, proliferation, cancer and longevity. And also it has been shown that blockage of PI3 AKT mTOR pathway can lead to increased anti-tumor activity. So PI3 pathway co-targeted therapy is now used. So the several therapies, including the PI3K inhibitor, AKT inhibitor, mTOR inhibitor, has been is under investigation. So in many cancers, this pathway is overactive and it reduces apoptosis and allows proliferation. So this is the main mechanism in this pathway. It reduces apoptosis and it allows proliferation. However, this pathway is necessary to promote growth and proliferation of adult stem cells, neural stem cells specifically. So once again, to summarize, mutations contributing to pheochromocytoma and paraganglioma have two general transcription signatures. Cluster 1 genes encoding proteins that function in the cellular response to hypoxia, mainly the HIF, and cluster 2 genes encoding proteins that activate kinase signaling, so mainly the PI3, AKT and mTOR pathway. So cluster 1 tumors are mostly extraadrenal paragangliomas, except for in VHL, and they have a noradrenergic biochemical phenotype, whereas the cluster 2 tumors are mainly adrenal pheochromocytomas with the adrenergic phenotype. So most cases of familial paragangliomas are caused by mutations in SDH, a subunit of genes, and they make up portions of mitochondrial complex 2. So what is the SDH complex? So the succinate dehydrogenase catalyzes the oxidation of succinate. So SDHB is one of the 4 protein subunits forming succinate dehydrogenase. The other 3 are SDHA, SDHC and SDHB. So the SDH complex is located on the inner mitochondrial membrane, and it participates in the tricarboxylic acid cycle and the respiratory chain, that is the electron transport chain. So SDHA converts succinate to fumarate as part of the TCA. This reaction also converts FAD to FADH2. Now electrons from FADH2 are transferred to the SDHB unit. Finally, the electrons are transferred to the ubiquinone pool via the SDHC, SDHD subunits. This function is part of the respiratory chain. So germline mutations in this gene can cause familial paraganglioma. So the SDHX genes are considered tumor suppressor genes and encode proteins that form the mitochondrial complex to, as I've told before, a crucial link between the Krebs cycle and the mitochondrial transport chain. So SDH is basically, it has 4 subunits and it's encoded by the nuclear genes. SDHA and SDHB form the catalytic domain, while the C and D anchor the complex to the inner mitochondrial membrane. And the assembly factors SDHAF1 and SDHAF2 are needed for the functional and structural integrity of the complex. So defects in the SDH genes result in succinate accumulation, and this is a competitive inhibitor of the 2-oxoglutarate dependent dioxygenases, HIF prolyl hydroxylases and histone or DNA demethylases. About the HIF prolyl hydroxylase I've told you before. So it basically, when you have a defect in the SDH, succinate accumulates, it inhibits the 2-oxoglutarate dioxygenase, and this leads to stabilization of HIF isoforms and hence the activation of hypoxic signaling. In patients with SDHD or SDHAF2 mutations, the penetrance depends on the mutation's parent of origin. So with rare exceptions, this disease is not manifested when the mutation is inherited from the mother, but is highly penetrant when inherited from the father. So this phenomenon is called maternal imprinting. So in SDHD or SDHAF2 mutations, which are dependent on the parent of origin, this shows high penetrance when it is inherited from the father. So there is a greater risk, or the risk is much increased when it is inherited from the father. Another mutation is TMEM127 mutation. So it falls in the cluster 2. It's a negative regulator of the mammalian target of rapamycin or mTOR. About the mTOR pathway I've told you before the introduction. So TEM127 mutations is usually associated with the family history of pheochromocytoma and also with sporadic pheochromocytoma. MAX mutations. Now MAX is the short form for MYC associated factor X. So loss of function mutations or the LOF mutations in MAX gene are associated with familial pheochromocytoma. So it's a component of the MYC, MAX, MXD1 transcription factor. So this regulates cell proliferation, differentiation, and apoptosis. So the loss of apoptosis here could result in the tumor proliferation and growth. So if the SDHX mutation is identified in a relative or a proband, annual clinical assessment is usually indicated for the early detection of pheochromocytoma or paraganglioma. Biochemical testings using fractionated metanephrin in plasma or 24-hour urine for the metanephrins should be performed annually in all carriers of SDHX mutation starting around age 10 years. So that's very important. Either from the plasma or from the urine, you have to measure the fractionated metanephrins, and that has to be performed annually if it is found, if the patient is found to be a carrier of SDHX mutation. Even and periodic imaging studies are also advised, because paragangliomas may be non-functioning or may be detected before the catecholamine secretory autonomy is evident. So even before the catecholamines are secreted, they could be found out through the imaging. So at-risk SDHX mutation carriers should have MRI of the abdomen, pelvis, chest and neck every 2 to 3 years, and total body imaging with I-123 MIBG or a gallium-68 or the DOTA, TATE or PET-CT should be performed every 5 years. So at-risk SDHX mutations are, for example, SDHD and SDHAF2 mutations. So the SDHX mutations are at risk to develop RCC, the renal cell carcinoma, and the periodic abdominal cross-section imaging also screens for this possibility. So they need to be screened out for a renal cell carcinoma as well. As new tumor associations are identified, additional surveillance will be indicated. Even interestingly, reports have identified SDHX mutations and pituitary tumor risk. So in the future, if the risk is clinically important, then even pituitary directed MRI can become part of the surveillance program. So I am just giving you the different kind of mutations. So let's start with the cluster 1. So the syndrome is SDHD mutation or familial paraganglioma type 1, and the gene is SDHD. So the tumors are basically around the skull base and neck. Sometimes it's in the medulla, mediastinum, abdomen, pelvis, pituitary. So it's vast. So basically it's around the skull base and neck, the familial paraganglioma type 1, and it is SDHD mutation. SDHAF2 mutation, the gene is SDHAF2, so it's also mainly around the skull base and neck. So the familial paragangliomas type 1 and type 2 mainly around the skull base and neck. So they include the SDHAF2 and the SDHD genes. So the familial paraganglioma type 3 or the SDHC mutation, the gene is SDHC. So it's also around the primary skull base and neck. Occasionally it's in the abdomen, pelvis. So basically around the skull base and neck. So familial paraganglioma type 4 or the SDHB. So this is different from the 3 mutations or the 3 syndromes that we have seen before. The type 4 is, it more involves SDHB. So as you see, the abdomen, pelvis and mediastinum is mainly involved. Medulla, adrenal medulla, skull base and neck could be involved in very rarely. So it's mainly the abdomen, pelvis and mediastinum, and it has got an important malignant potential. The SDHA mutation, as in SDH C and D, it's mainly around the primary skull base and neck. Another syndrome is von Hippel-Lindau disease. So the gene is VHL. Adrenal medulla is usually affected and it's bilateral. Occasionally, there may be a paraganglioma from skull base to pelvis, but that's very rare. Hereditary leiomyomatosis and renal cell carcinoma, called the Reed syndrome. It's caused due to fumarate hydratase mutation, and the gene is FH. So it's a multifocal and metastatic condition. So as you see, it is associated with leiomyomas, fibroids, and renal cell cancer. HIF2 alpha, the gene is HIF2 alpha. It is associated with paraganglioma, polycythemia, and rarely somatostatinoma. So HIF2 mainly with the paraganglioma and polycythemia. Now, familial erythrocytosis associated with mutations in the PDH1. The gene is EGLN2. So, as you see from the syndrome itself, you know there will be polycythemia. So there will be associated pheochromocytoma also, and paraganglioma. So the gene is EGLN2. And familial erythrocytosis with PDH2, the gene is EGLN1. So it's just a reverse. Like in familial erythrocytosis with PDH1, the gene is EGLN2, and in the familial erythrocytosis with PDH2, the gene is EGLN1. So it's the same. Polycythemia with pheo and paragangliomas. Finally, the KIF1B, it's associated with neuroblastoma. So if you come to the clusters 2, there is a MEN2A and MEN2B. So the gene is RET, and adrenal medulla is involved, and frequently bilateral. Also the MAX genes, adrenal medulla is involved. And familial pheochromocytoma with TMEM127, adrenal medulla again is involved, with an involvement of renal cell carcinoma. NF1 also involving the adrenal or periadrenal. The gene is NF1. So the syndrome is neurofibromatosis type 1. So these are in a nutshell the genes involved and the syndromes associated with hereditary forms of pheochromocytomas. Thanks for watching this presentation. Bye.